Okay, welcome everybody. Happy New Year to all of you. What I wanted to do today was to continue with the mixed acid-base disorders. They're sometimes called complex acid-base disorders, so the terms are interchangeable. And the goal will be to how to recognize these very quickly. So I'm going to be popping these questions up, and what I want you to do is to very quickly say, is it mixed or not mixed? And then we'll go into more details after that. So again, if they're not mixed, saying the same thing, they're not complex, that means that the change in the bicarbonate compared to the change in the PCO2 must follow one of these rules. If they follow one of these rules, by definition, it's not mixed. So if you see, even if you don't know what they are, if you see the change in the bicarb, the change in the PCO2 of roughly 1:1 or 2:10, or in chronic respiratory alkalosis, roughly 2:1 or 5:10, then if the bicarbonate's down, it's one of these three things and it's not mixed. And conversely, if you see the bicarbonates elevated, then if you see one of these three ratios, then it's one of these three acid-base disorders and not mixed. It's not complex by definition. So the key is to look immediately at the delta bicarb to delta PCO2 and decide, does it follow one of these six rules? If it does, then you know it's a simple acid-base disorder. It's one of the six. That's the thinking. If it's not one of these six rules, then it's a complex disorder, potentially. And I'll talk about why that's not always the case. Okay, sorry. Okay, so here's the first case. So if someone could just unmute quickly and forget what the disorder is, just decide, does it follow one of the six rules? And if it does, then let me know it does, and then try to commit to what the acid-base disorder is. So it's a male, so you know that the bicarb went up by 10 and the PCO2 went up by 7. Is this a simple disorder or is it a complex disorder? Anyone?
It is simple disorder. This is a metabolic alkalosis.
Yes, very good. So it's a simple disorder because it follows one of the six, and fine-tuning that, it follows one of the three that was in the up direction, and it's the rule for metabolic alkalosis, which is for every 10 increase in the bicarbonate, your ventilation decreases so that your PCO2 goes up by 7, or in other words, the PCO2 changes by 70% or 7/10 of what the bicarbonate changed by. Very good. So this is a metabolic alkalosis, and it's a simple disorder, and it follows that rule, which you just have to memorize these rules. I'll send you afterwards, I'll have Ruth send you a nice paper by Nick Medias in the New England Journal. It's a little bit old, but the rules haven't changed since they were first discovered in the 1960s. This paper is from 2010, but it's just a very nice review for your boards and for following patients clinically, and basically reiterates the things I'm saying, but it's just a nice short summary of some of these ideas that it's worth going through to review. Okay, here's another patient. So again, decide, is this simple or not? And it's a little more complicated here because you'd first say there's nothing going on. But it's another example of how you can have a mixed disorder. In this particular case, and we'll talk about it, there may be a mixed disorder even though nothing has changed, but it's not because one of the acid-base rules isn't what it should be. It's for another reason. So think about this just for a minute and tell me what you think might be going on. Okay, this is a little more complicated. It's not, the first thing you would think of if you saw it was there's nothing going on. So it doesn't even seem to fall into the topic of, is this a complex disorder or not? But when you look at the numbers more definitively, you see that there's an anion gap elevation here. So how can you have an anion gap elevation if your bicarbonate's normal? And the answer is the bicarbonate would not have been normal unless you have another acid-base disorder present. So the fact that you have an elevated anion gap tells you, if it's endogenous, that the proton came in with the anion. And if the bicarbonate's normal, you must have had something else raising the bicarbonate so that after the proton came in, you end up with normality. So you have at least two acid-base disorders. One, an anion gap metabolic acidosis, as evidenced not by the pH, not by the bicarbonate changing, but because the anion gap went up. And since anions come into the body with a proton, you must have a metabolic acidosis, meaning you had a proton load endogenously or exogenously, but in this case, most likely endogenously. And you have a change in your anion gap. Now, in this particular case, sometimes you have this without a change in the anion gap. And that's much harder to discern, because if the anion gap is normal, in other words, you could have a hyperchloremic metabolic acidosis and a metabolic alkalosis, and everything looks normal. The anion gap looks normal, the bicarbonate looks normal, the PCO2 looks normal, but you still have two acid-base disorders. It's just that they were equal in magnitude and opposite in direction, so you end up with no change in the bicarbonate. And remember, when you say osis, it's a process. It's not the same as emia. So when you say metabolic acidosis and metabolic alkalosis, it doesn't mean that the pH or bicarbonate or PCO2 have changed. Osis refers to the tendency for that to occur. It refers to the process that would sometimes lead to an emia meaning a change in the blood concentration. So you could get an examination question where you have completely normal acid-base numbers and you have a non-gap acidosis, let's say from diarrhea, whatever it is, RTA, whatever it is, plus metabolic alkalosis from Lasix or vomiting or whatever it is, and they happen to be quantitatively having the exact same effect on the bicarbonate concentration, but opposite in direction, you're not even going to have a clue at all that the anion gap changed. The only thing you might see is hypokalemia or dysnatremia. So you have to, or pre-renal failure. You have to look for these other clues. But if you just look simplistically at the anion gap and the acid-base numbers, you may see no change. Now, if you have a patient with, let's say, lactic acidosis or ketoacidosis, who's vomiting also, and you have normal acid-base numbers, at least there you see the anion gap changed. And so that would tell you had a proton load, and then you have to ask yourself the paradox, how is it possible to have a normal bicarbonate? And therefore, the bicarbonate clearly must have been higher to begin with. But if you don't have an elevated anion gap, it's even harder to figure out. So here's a mixed disorder where it's not due to an abnormality in the acid-base rules. It's because you have two acid-base disorders present that are both metabolic. And so the clue is that if you take you always have to add the change in the anion gap from normality to the current bicarbonate, and that should equal the bicarbonate of 2425. If you take the current bicarbonate and you add the change in the anion gap and you get a number above 2425, you know that you have two acid-base disorders present. So it's another clue. In addition, and I'll review these at the end, it's another clue in addition to the fact that the acid-base rules didn't seem to be followed simplistically, that you have more than one acid-base disorder present. So here's another patient. And again, just quickly decide, is it a simple acid-base disorder or not? Again, remember, in females, the PCO2 is a little bit lower than 40. The bicarbonate isn't quite 25. It's usually 23, 24, just to be exact. So does this follow any of the three acid-base rules where you have a drop in your bicarbonate? Or the change in the PCO2 and the change in bicarbonate different from one of those three rules? Well, In metabolic acidosis compensated, they're roughly 1-to-1. It's a little bit more drop in the PCO2. If you want to be exact, for every fall in the bicarbonate, the PCO2 falls by 1.2. But they're basically the same. So if you see a change in the PCO2 and a change in the bicarbonate from normality that are approximately the same, that's compatible with a simple metabolic. You don't use the word simple, but I'm just using that word as opposed to the word complex. But you have a single acid-base disorder, which is in this case a compensated metabolic acidosis. Okay. So again, these numbers fit the metabolic acidosis rule, where you have roughly the same change in bicarbonate to change in PCO2. So you can quickly start getting the pattern recognition where if you look at the bicarbonate, it's below normal, and the PCO2 and bicarbonate look like they fell by the same amount, you know you have a metabolic acidosis compensated. You don't have to think further. This is, in fact, the easiest one to recognize because the changes are roughly the same for both. Okay, here's another one. So again, try to decide, is this a simple acid-base disorder or not? Again, it's a drop in bicarbonate, so you have to decide, is it metabolic acidosis compensated rule, acute respiratory alkalosis rule, or chronic respiratory alkalosis rule? And again, you just have to memorize the three. It's clearly not metabolic acidosis because the changes aren't 1-to-1. Okay, well, it's either acute or chronic respiratory alkalosis or neither. It could be none of the three, and it could be a mixed disorder. So if it was acute respiratory acidosis, let's say someone got scared or came to the doctor and white coat syndrome, and the PCO2 fell from 40 to 20, if it was acute, you'd expect the bicarbonate to fall by roughly twice that, or by 4. So for every 10 fall in the PCO2 acutely, your bicarbonate falls by 2. That's the acute respiratory alkalosis rule. So here the PCO2 fell by 20 roughly. We don't know the original, and that's always a problem. We have to assume what the original numbers are. But if we assume it was 40, the PCO2 fell by 20. So if this was white coat syndrome and acute, you'd expect the bicarbonate to fall 2 for every 10 fall in the PCO2. So it should have fallen by 4. So it can't be 18. 18 is too great a fall. So it's not compatible with acute respiratory alkalosis. So the question is, could this be chronic respiratory alkalosis? It's also one of the easy ones to recognize because it's 2-to-1. So for metabolic acidosis, the changes are equal. And for chronic respiratory alkalosis, the changes are 2-to-1. So for every 10 fall in the PCO2, the bicarbonate would fall half of that. So if it's acute, for every 10 fall in the PCO2, the bicarbonate falls by 2. If it's chronic, it falls another 3. So if the hyperventilation lasted more than acutely, the bicarbonate would fall initially by 2 due to the acute respiratory alkalosis phenomenon, but it would fall another 3, so the total fall would be 5. So here, the PCO2 fell by 20, we'd expect the bicarbonate to fall by 10. It should be 15, and it's not, it's 18. So this kind of thinking shows you that it's not either acute or chronic respiratory alkalosis, and it's not metabolic acidosis, not 1-to-1, it's not 2-to-1, and it's not what you'd expect in acute respiratory alkalosis. So this must be a mixed acid-base disorder. So the causes of why it doesn't follow one of these 3 rules is either you're not in a steady state. And by steady state, remember always that the acid-base rules take time. The 6 acid-base rules that you memorize don't occur immediately. They each have their own time dependency. And if you haven't achieved enough time, you're called what's not being in a steady state. And if you're not in the new steady state, then you could have numbers in between. So that's one possibility. It is possible that it was a simple acid-base disorder, and you just caught the patient in between the time where the changes were starting to occur and when they stopped occurring. And we call that not being in the steady state. That's one possibility. And the other possibility is that you didn't have, if it's a respiratory acid-base disorder, you didn't get the appropriate renal response, either because the patient's on some drug that affects the kidney's acid-base response, or there's CKD, or there's something going on preventing the kidney responding as it normally would to a respiratory acid-base disorder. Remember, these rules assume physiologic normality. In the absence of that, if you have additional renal pathology, you're not going to get the typical renal response to the respiratory acid-base disorders. Just like you're not going to get the typical ventilatory response in metabolic acidosis and alkalosis if you have some medullary or intracerebral abnormality going on. The lack of the appropriate response suggests potentially other organ pathology. But again, you may just simply have not waited long enough, so you're not in a steady state. Okay, here's a 60-year-old male. Look at the numbers. You've got an elevated bicarbonate. Think of the three cause acid-base disorders that do it and decide which of the three it is. Again, is this a metabolic alkalosis? Is this acute respiratory acidosis or chronic respiratory acidosis? You have to, again, know the three rules and see what it is. Well, it's clearly not metabolic alkalosis because, as was said initially to that original patient, the PCO2 should be going up 70% of what the bicarbonate went up. And clearly, it's gone up way more than the bicarbonate went up. So you're either dealing with acute or chronic respiratory acidosis, and you have to know the acid-base rules. So if it's acute respiratory acidosis, for every 10 increase in the PCO2, the bicarbonate goes up by 1. So here the PCO2 went up by 3 times 10, a little more than 3 times 10. So the bicarbonate should go up by about 3. So if the PCO2 went from 40 to 50, the bicarbonate should go up by 1, from 25 to 26. If the PCO2 went from 40 to 60, the bicarbonate should go to 26. If the PCO2 went up to 70, the bicarbonate should go to 27. So clearly it's not 27. It's 36. So the question is this compatible with chronic respiratory acidosis? And for that, for every 10 increase in the PCO2, the bicarbonate goes up further than the acute by an additional amount, such that it goes up 3.5 total from the original. So if the PCO2 went up by 10, the bicarbonate should go up by 3.5. If the PCO2 went up by 20, the bicarbonate should go up by 7. If the PCO2 went up by 30, the bicarbonate should go up 10.5. Here it went up a little more than that. So the bicarbonate should go up, when you do the math, about 11.2 or so. So it's perfectly compatible with chronic respiratory acidosis. This is what you would expect in a chronic bronchitic or someone who's chronically hypoventilating. There's no other acid-base disorder present. The elevated bicarbonate is all due to the chronically elevated PCO2. So this is compatible with chronic respiratory acidosis. And remember, the rule that you need to memorize is for every 10 increase in the PCO2, the bicarbonate will go up 3.5 from its original level. Okay, here's another patient. Again, look at the change in PCO2 and change in bicarbonate and decide, is this a simple acid-base disorder or not? Again, we're dealing on the upside. So we're either dealing with metabolic alkalosis compensated or acute or chronic respiratory acidosis. Here, the PCO2 and change in bicarbonate, as the case before, could not possibly be due to a compensated metabolic alkalosis, because if this was a metabolic alkalosis and the bicarbonate went up roughly by 8, the PCO2 as a compensation should have gone up 70% of that, or 5.6. The PCO2 should be around 45, 46. So clearly it cannot be, these numbers, the pattern of the numbers don't fit a compensated metabolic alkalosis. So you're either dealing with an elevated bicarbonate due to acute respiratory acidosis or chronic respiratory acidosis. So again, the same thinking. If it's acute respiratory acidosis, for every 10 increase in the PCO2, the bicarbonate had to go up by 1. So here the PCO2 went up by 40. So the most the bicarbonate could have gone up acutely is by 4. So the bicarbonate should be 29 or 30. And clearly it's not. So it can't be acute respiratory acidosis. Well, what about chronic? Could this be a chronic bronchitic? Well, again, for every 10 increase in the PCO2, the bicarbonate should have gone up 3.5. So if the PCO2 went up by 40, the bicarbonate should have gone up 4 times 3.5. And clearly it didn't go up quite as much as it should have. So we're left again with not acute or chronic respiratory acidosis. So this must be a mixed disorder because it doesn't follow either of the two rules. And as we said, it doesn't follow metabolic acidosis compensated either. So again, the same thinking. Either you're not in a steady state and you were between acute and chronic respiratory acidosis. This could have been someone who was put on a ventilator and they were hypoventilating the patient, and the ventilator was decreased for a time frame that would be between acute and chronic respiratory acidosis. It wasn't quite hypoventilating the patient long enough for a new steady state to be achieved. The bicarbonate is still increasing, and it hasn't plateaued out yet in the steady state phase. So that's one possibility. The other possibility is that you have a renal abnormality, and the bicarbonate, in response to the elevated PCO2, can't go up as much. Either the patient has CKD or something else going on in the kidney, preventing the predicted renal response in the bicarbonate concentration. And you could only know clinically, if you were following the patient, which of the two it is. Okay, here's another case. Again, think the purpose of today's talk is to quickly decide, is this a simple or complex disorder? So it's a patient who's on Lasix and who had ketoacidosis. You can already be thinking of what the acid-base disorders might be, but just looking at the PCO2 and bicarbonate, you have roughly the same change in both. The PCO2 changed by 6. And again, we're assuming it started at 40. We don't know. Assuming the bicarb started at 25, it also changed by 6. So we have a 1-to-1 change. That's metabolic acidosis compensated. That follows the metabolic acidosis simple rule. But there still might be something going on. So what might be going on, you can only discern not from the acid-base rule perspective, but by calculating the anion gap. So when you calculate the anion gap, it's 130 minus 95. You can see that you have an elevated anion gap. And again, when you add that change in anion gap from normality to the bicarbonate, you don't get 25. So here is that sort of second type of thinking where you always must add the change in the anion gap to the current bicarbonate. And if you don't get a bicarbonate of 24, 25, by definition, you have another acid-base disorder present, because you can't have an anion gap that's so elevated in a normal bicarbonate unless you have something else that was elevating the bicarbonate and making it bigger than you would have, or higher concentration than you would have thought otherwise. Okay, so let's talk about some of these things that are a little more complex to understand. Not being in the steady state. Again, remember, these rules are only for the steady state. So you have to wait long enough. If you don't wait long enough, they're not going to apply, and you could erroneously think you don't have a simple acid-base disorder. So always make sure that the acid-base disorder has been occurring long enough. And oftentimes clinically, we just don't know, unfortunately. Same with the second set of 3 rules. You have to wait long enough. And again, memorize how long these things take. They all take different periods of time. The compensation of metabolic acidosis doesn't occur immediately. The 1.2 PCO2 change to 1 bicarbonate, or if you want to use the old Winters formula, which you don't need to do anymore, it takes about half a day to a day for that ventilation to reach its new steady state. Metabolic alkalosis, the 70% rule, takes a bit longer. Chronic respiratory acidosis, if you raise the PCO2 for whatever reason, either someone went unconscious or went on a ventilator, for whatever the reason, it takes 3 to 5 days for the bicarbonate to stop increasing and reach a new steady state. And respiratory alkalosis, if you drop the PCO2 for a period of time that's longer than just white coat syndrome or anxiety, acute anxiety, it's going to take 2 to 3 days for the bicarbonate as it's falling to start plateauing out and stop falling further. So you got to wait long enough. There's another subtlety which is confusing to people, and that sometimes you'll see attendings say you have a GAP and a non-GAP metabolic acidosis, and that's not usually that common. It's pretty uncommon to have diarrhea and ketoacidosis, or RTA and lactic acidosis, whatever the initial cause might be. It's far more common in the setting of an anion gap metabolic acidosis to have what's called a hyperchloremic pattern. And by pattern, it means that you don't have a disease or a clinical cause of the hyperchloremic metabolic acidosis like RTA or diarrhea, these kind of things. But you have a hyperchloremic pattern even without a disease that would cause a hyperchloremic or non-GAP metabolic acidosis, for an important concept. And that is a concept of that in nephrology, we're always dealing with inputs and outputs. And the same is true with anion gap type metabolic acidosis. So as we discussed before, you have a proton coming in with an anion. The anion does not cause the metabolic acidosis. It just comes with the proton. The anion raises your anion gap, and the proton binds to bicarbonate and lowers the blood bicarbonate concentration. But remember that the anion gap not only comes in, it also leaves the body, and it leaves the body through your GFR, and then it depends, the magnitude of the excretion depends on whether there's going to be tubular absorption or not. So certain anions are absorbed more avidly, and the excretion rate depends on your GFR and the tubular transport. Others aren't absorbed as well, and it's mainly a GFR issue. The GFR issue typically is with ketone bodies. They're not absorbed that well. So the GFR really determines the output. So you can have the exact same input and 2 different anion gaps in the blood, depending on what your GFR is. You can have a patient with volume depletion, osmotic diarrhea, diuresis, or vomiting with ketoacidosis with a horribly low GFR, and their anion gap's going to be sky high. You can have another patient with the exact same magnitude of proton and anion input into the body, but their GFR is great. Either they weren't vomiting, or they didn't have as much osmotic diuresis, or they were volume repleted by an MD with an IV, and they have a great GFR. All those anions are going to come out in the urine, and the anion gap's going to hardly change. And the only clue is they have ketone bodies in your urine, and you're going to be fooled into thinking they have either complete hyperchloremic metabolic acidosis. If all the anions came out, the anion gap will be 10 or 11. It'll be completely normal. Or it'll be in between, where some of the anions came out and the anion gap looks like it is not as increased as it should be. And that's when people start saying they have a mixed anion gap and non-anion gap metabolic acidosis. It's not correct. They have an anion gap metabolic acidosis only, but the anions were excreted in part or wholly, and it has now a hyperchloremic pattern, either in part or whole. So you have to, from now on, distinguish hyperchloremic pattern from the word hyperchloremic metabolic acidosis. And unfortunately, 99% of attendings don't do that. And you can be erroneously clued into starting to look for other non-GAP metabolic acidoses, which is not correct. It's all due to the one cause, and the pattern you get in the blood is solely dependent on what your GFR is and how well you've excreted those organic anions. And the clue in these patients is you won't find ketone bodies in the blood, and you won't find an elevated anion gap, either wholly or to the extent you would think you should, and you will find these things in the urine. You got to remember to look at the urine for the ketone bodies. You'll find them all there, and that'll be confirmatory that you were right, that this is simply just an anion gap metabolic acidosis. With lactic acidosis and other organic acidoses, it doesn't occur as commonly because lactate's much more avidly absorbed. Now, it does occur with D-lactate. You can be fooled with D-lactate because D-lactate isn't absorbed as well. But in your exam, it'll typically be with ketone bodies, where and so remember that unlike residents and medical students think, the anion gap does not reflect necessarily the severity of the ketoacidosis. People tend to think, well, the anion gap is sky high, I have a rip-roaring ketoacidosis. That's not true. It ignores the important thought that the anion gap is equally as determined by how much the anions come out in the urine. And again, you can have two people, same exact amount of anions coming in per unit time. One has an elevated anion gap that's sky high because they got ESRD or CKD stage 4 or 5 or severe prerenal failure, whatever it is. And the other has a GFR that, it's 120 liters a day. Fantastic GFR. All the anions come out in the urine. Anion gap doesn't even go up. Both have the same degree of ketoacidosis. Both have the same degree of a drop in bicarbonate. But one has a hyperchloremic pattern, either in part or whole, and the other doesn't. So please remember that, because this is a confusing area of nephrology where people call this a mixed disorder, but it's actually not. It's a mixed pattern chemically, but it's not a mixed disorder as far as causal etiology. So just to summarize, there are a bunch of patterns that you'll see, a bunch of cases clinically where you need to commit to a mixed acid-base disorder. Some people will call this complex. One is that you're not in a steady state. So remember that all the rules require that you wait long enough. You also have to always add the change in the anion gap to the current bicarbonate. And if you get a number that's greater than 24, 25, you have mixed disorder. You could have normal acid-base numbers with clinical causes that suggest that you have more than one acid-base disorder. That would occur when you don't have anything else going on chemically, like a patient with diarrhea and who's vomiting, and the change in bicarbonate in a magnitude way up and down is equal. So you have normal PCO2, normal bicarbonate, normal pH, and your anion gap's normal because the diarrhea causes a hyperchloremic metabolic acidosis. And the only clue is that you look at the patient and they have rip-roaring diarrhea and vomiting. You'd want to think that maybe that's going on. Don't just look at the numbers and say, oh, there's no acid-base disorder. There may be. You may have no clues other than the clinical, but that should key you into looking at the potassium. If you have severe hypokalemia, that'll be a clue, because hypokalemia tends not to occur, and you'll learn that as you go along, without acid-base disorder commensurate with it. It's pretty unusual in clinical medicine to get a change in the potassium without an acid-base disorder. It doesn't occur often, unless you have familial periodic paralysis or something where you have potassium going into a different compartment. But if you have whole body or input-output changes in potassium, it typically occurs commensurate with a change in your bicarbonate. People often miss. And the other clue would be dysnatremia, that you have a sodium of 131, a potassium of 2.4, but your PCO2, pH, and bicarbonate are completely normal, as is your anion gap. Don't think there's not an acid-base disorder going on there. There very well could be. Along those lines would be someone with normal acid-base numbers, but with an elevated anion gap, as we talked about in the ketoacidosis situation. You can also have lack of appropriate compensation in metabolic acid-base disorders. Remember, that also means you have a respiratory acid-base disorder. So if you have ketoacidosis, but the PCO2 is not changed roughly 1-to-1, then you must have a respiratory acid-base disorder, either in the up or down direction, alkalosis or acidosis, depending on what your PCO2 is. And also, remember, the converse is true. If you have a respiratory acid-base disorder and the bicarbonate is not what you'd expect for acute or chronic, whatever the respiratory acid-base disorder is, it could be you've got renal pathology and the bicarbonate's just never going to achieve what the simple acid-base rule predicts it should. And you can have also two categories of the same metabolic disorder. You could truly have, let's say, diarrhea and ketoacidosis, or you could have a patient with RTA who got lactic acidosis, and therefore they will have two types of metabolic acid-base disorders. Also, you could have metabolic alkalosis with a chloride sensitive and chloride resistance. For instance, let's say you have a patient with Gilman's or Barter's syndrome. Their metabolic alkalosis is chloride resistant, but they can also vomit. They can also be on a diuretic. And now they've got two causes for their metabolic alkalosis, the chloride resistant, which is their Gilman's or Barter's, and a component that's going to respond when you give chloride due to vomiting or diuretic use in the past. So these are just a summary of some of the clinical causes of why you can look like you have more one acid-base disorder or pattern. And I think I'll stop there and take any questions. And after the talk, I'll have Ruth send you out Medias's nice article on the acid-base rules. Anyone have any questions? What we went over today? Okay, everyone, again, Happy New Year to all of you. And I wish you a happy and successful and healthy year. And we'll see you next week.